Thank you very much for the introduction, and a thank you to Professor Kotian Hai and the organizing committee for having me be a part of Singapore Live 2022. It really is a pleasure to be here with you all today. So I've asked to speak about percutaneous therapy of calcific mitral stenosis. And we look at these patients, when we're talking about MS, it really is about mitral annular calcification. We know that patients who have MAC have a very poor survival. This is a study from our center that looked at 430 patients. Three-quarters of the patients had MR, 25% had MS, but it didn't matter whether you had MR or MS, the outcomes were quite poor. And overall, the 3-year death rate was about half of the patients, with half the patients also having heart failure hospitalization. So very poor survival for some of this pathology, which is really some of the most extreme pathology that one may see. So here on the left-hand side, this is an echocardiogram showing what looks like a significant mitral annular calcification. But when we do a CT scan here, we can see that actually this MAC is one of the most extremes in terms of pathology and poses a number of challenges for how we want to treat these patients. When I think about calcific mitral stenosis or severe MAC, I think of that as the Goliath in the room. And you have somebody like me with something like a catheter who would be aspiring to treat such patients. And that aspiration has to be very high because this disease is very complex. But this is an example of how it's done. This is a 73-year-old woman who had calcific mitral stenosis. And what we can see here is that with a transseptal approach using a balloon expandable valve like a SAPIEN prosthesis, this is technically quite feasible. Certainly, there's an evaluation that is required with CT scanning for planning, but all said and done, this is an overnight procedure in an appropriately selected patient. Now, in the early experience with this is published by Myra Guerrero a few years ago, looking at the first 116 patients. There was a good degree of success, but also a good degree of risk. Technical success was 77%. Most of the patients had transseptal approach, but LVT obstruction occurred in about 11%. And nevertheless, the 30-day mortality was still 25% for these patients. But it's important to keep in mind that these data were generated with some of the earliest technology before there was really a good understanding of how to use CT and echo and for proper therapy of these patients. And we've gone further and done further analysis. This is also by Myra, published last year in JACC Imaging. What she came up with is a scoring mechanism in which we're able to essentially quantify the risk of sapien embolization or other adverse events. And this is on the left-hand side. One can see here, looking at the MAC on CT, measuring thickness distribution involving the trigones as well as the leaflets. And obviously, the more of these features that are present, the more favorable this pathology would be for treatment with a SAPIEN, a balloon expandable valve. But it's important to keep in mind that these scores are still not perfect. So here on the left-hand side on the y-axis is the score. And then we have two columns in which green represents a successful case and blue and red represents embolization or migration. And what we see here is that despite a high MAC score, there was still a considerable number of patients who had embolization and migration. And this is important because despite the score, we really have to use our judgment and obviously have the expertise of the operator in order to be successful with these cases. Now, to treat these patients with a balloon expandable valve, there are two trials that are going on in the United States. The Mitral 2 pivotal trial is a 210 patient study that involves transseptal valve and MAC and medical arms. On the right-hand side, there is also the Central study, which is a surgical-like approach in an EFS with open surgery for 30 patients using a balloon expandable valve and calcific mitral disease. Now, another way of treating these patients is not to go transseptal, but to go transapical. And this is how it was originally done. This is from our paper on TMVR for severe MAC. We do have to be careful about LVT obstruction. We have to be able to size a valve in a relatively less compliant annulus. Sometimes there are spicules and calcified leaflets that have to be mobilized. We do have to think about the sealing segment of these prostheses, whether you're transseptal or transapical. And obviously, we really want to focus on intra-annular displacement placement because these valves simply can't be pushed or pulled into position once they're deployed. So as one possible way to treat these patients, this is the Tendyne dedicated prosthesis for mitral annular calcification. It's a transapical 34 French system that's contoured to fit the mitral annulus. It's got a double frame design. It's got an anchoring tether with a hemostatic pad. It doesn't require pacing or bypass to deploy, and it's fully retrievable and repositionable. And this is how an example. This is an example of how it can be done in a patient with severe mitral stenosis. In this case, this patient had oversizing of the prosthesis by 50% in the commissural range. And here in this patient, there was a neo LVOT of only 260. There was prior AVR with a large spicule. And here on the right-hand side, we could see that this patient had a severe mitral stenosis being treated with the Tendyne prosthesis. And this is how it was done in this patient. The key to this is an intra-annular deployment. You want to deploy the valve inside the native valve as much as possible because, again, one cannot pull these prostheses into place. And then we want to be sure not to pull too much, but sometimes you can see this rise in the atrial cuff from pulling too hard. And that's corrected by less tension on the prosthesis, but here there will be some rise because of oversizing. And with this, one can see here, and despite this really oversized valve, there's an excellent result with a gradient of only 2 and complete relief of any MR that was present. And here are some follow-up studies showing what a dedicated valve looks like for these patients with severe calcific disease. Here, this is a post-fluoro image, and here's a corresponding CT image done at 30 days. And this shows the anatomic shape of the Tendyne valve and how it fits in that extreme pathology of the mitral valve. In the early experience with this transapical approach, it's been very positive. 20 patients with no need for intra-aortic balloon pump, no ECMO, no conversion to surgery, no 30-day deaths, and relief of MR in all patients. And this is currently in progress, and in the pivotal clinical trials in the United States, both Summit and Apollo have MAC arms. And certainly we look forward to seeing how these two devices work in these patients. So when it comes to catheter-based options for calcific mitral disease, or MAC, it is possible to achieve success if you have a device that's precisely aimed. The early data are promising for TMVR, but there are anatomic exclusions that are present, and the IDE studies hopefully will be informative. And with that, I'd like to thank you very much and look forward to seeing you all again very, very soon.